I'm Dr. Silva, and I'm going to talk to you today about serotonin syndrome. Patients have come into my office on numerous occasions telling me, just very casually and offhand, that they experienced quote unquote serotonin syndrome. And they are really referring to a very serious condition that's not super common. It's not rare, it happens, but maybe they were having side effects to their medications, but they weren't having serotonin syndrome. Serotonin syndrome would have sent them to the emergency room and gotten them admitted. It can be potentially fatal. And what it is, it's caused by the synergistic action of more than one serotonergic medication. Okay, so it's not caused by overdosing on an SSRI or overdosing on a tricyclic antidepressant with serotonergic activity or any of the other medications that can cause it. I will qualify that and say maybe if you overdose on ecstasy, MDMA, which is a methamphetamine that has strong serotonergic activity, a drug of abuse in that sense, but not a pharmaceutical. When it happens in clinical practice, it's because a patient either intentionally overdoses or they're taking two medications that are both serotonergic by maybe different mechanisms of action, and there's a synergism, and the dose is too high, and there's a perfect storm, and they get very sick, and they develop this syndrome. And it's usually seen when the practitioner combines an MAOI, a monoamine oxidase inhibitor, with another serotonergic agent like an SSRI. And that's a huge mistake. That's malpractice. You don't ever combine monoamine oxidase inhibitors, MAOIs, with any other kind of antidepressant and numerous other medications that can also lead to this serotonin syndrome. Just very quickly, and there's another video on MAOIs. MAOIs block an enzyme irreversibly, most of them. There's one that does it reversibly, but they irreversibly block an enzyme that catabolizes serotonin at the synapse and thereby terminates the action of serotonin at the synapse. And so that's one physiologic mechanism by which serotonin stops acting on its target neurons and receptors, because you're clearing it away by catabolizing it, it's because it's a monoamine neurotransmitter, and so the body will digest it away. And so that's one mechanism, along with reuptake inhibition and some other things that happen to reduce the action of serotonin. So if you block that enzyme, you increase serotonin and also dopamine, which is also a monoamine. These medications are used to specifically do that. You're trying to increase the level of neurotransmitters, but they're not used much because of these potential interactions and interactions with food. Even if you combine one of these medications that blocks the enzyme that blocks the catabolism of serotonin irreversibly, then for the next couple of weeks, if you then combine it with another agent that's increasing serotonin, you're going to have so much serotonin at the synapse that this could lead to this potentially fatal serotonin syndrome. And so it's classically seen when MAOIs are combined with other medications, and the washout period, which needs to be 2 weeks before and after. So if you take an MAOI, you can't take another antidepressant for 2 weeks, or if you're taking another antidepressant and you're planning to switch to an MAOI, you can't start the MAOI for 2 weeks. You can't do a cross taper where you're starting one medication while you're coming off of the other one. So we see it when we combine SSRIs and MAOIs, when we combine MAOIs and tricyclics. Only clomipramine and imipramine, anafranil and tofranil, are the tricyclics that have enough serotonergic activity that they would cause serotonin syndrome in overdose or in combination with other medications. The other ones are noradrenergics, so nortriptyline, amitriptyline, protriptyline. Those medications have negligible serotonergic activity. Also, medications that are not antidepressants, such as tramadol, which is an opiate. It's a very weak opiate pain medication, which also, though, has serotonin and norepinephrine reuptake inhibition properties. So it's a weak SNRI, like Effexor and Cymbalta. And so it can, in combination with the wrong medications, including MAOIs, cause serotonin syndrome. You also see it with drugs of abuse, as I've mentioned. You can see it with MDMA, you can see it with other amphetamines, with cocaine. You also want to be careful combining medications like dextromethorphan, which is found in over-the-counter cough syrup, the DM and Robitussin DM. That can cause it in overdose in combination with these medications. Probably not as commonly as mixing an MAOI with clomipramine. That's very risky, whereas taking cough syrup while you're taking a high dose of Paxil, that's just not going to happen. And so it's not as common as patients think it is, but I've never even seen it. But it's also because it tends to occur because it is a consequence of bad prescribing, of malpractice, or of a patient overdosing. So the syndrome consists of basically a triad. The first is agitation and a clouded sensorium, a delirium. The patient is confused, maybe even hallucinating. These are just all the possible symptoms. A patient doesn't necessarily have all of the symptoms, but what you see is a change in their mental status. They're not clear as a bell. They have a delirium that is all the way from mild to quite severe, and they're very agitated, and they can be aggressive. You also have hyperreflexia. You see that their reflexes are very strong. They can have spontaneous myoclonus, which is jerking of the muscles and tremors, and they also can have induced myoclonus, and they can have ocular clonus. But their muscles are contracting. This can be a real problem because over time, those muscles can break down, and the increased myoglobin in the bloodstream can actually cause kidney failure. That's called rhabdomyolysis, and that can be life-threatening as well. You also have autonomic instability, which is characterized by very unstable hemodynamic parameters. So you'll see an increased pulse. A lot of the time the blood pressure is elevated, but it can also be very, very low, and it can be just very unstable where the blood pressure is up and down and up and down. So you can have problems with hypotension and shock if you overcorrect for the hypertension, but usually on presentation you're seeing the elevated blood pressure and the elevated pulse rate. You also see sweating, diaphoresis, and you see hyperthermia. The patient's temperature is elevated, it can be very high, and that can be very dangerous and life-threatening as well. So we see these three symptoms: the confusion, the mental confusion, the hyperactivity of the muscular system of the body, and the instability of the autonomic system, which the vital signs are very unstable. How do you treat serotonin syndrome? You stop the offending agent, obviously, and serotonin syndrome tends to come on quickly within a day, and it resolves fairly quickly in most cases that are not very severe and that don't require a lot of supportive care. But that's basically what you would give: is you stop the offending agent and you give supportive care, which could involve cooling the patient if necessary, stabilizing the blood pressure, usually giving antihypertensives initially, and of course, you hydrate the patient so that you stay normovolemic so that you can further stabilize the vital signs. And with all the sweating, and the patients are probably not going to be eating or drinking for at least 24 hours. And also to keep the kidneys hydrated, keep them working. Benzodiazepines and muscle relaxers can be used to treat the myoclonus. And cyproheptadine is a serotonin receptor antagonist. It's an antihistamine that also has serotonin 5-HT1A blockade, and it can be used to mitigate the effects of all this extra serotonin that we have floating around. There are other conditions that are very similar, syndromes, constellations of symptoms that are very similar to serotonin syndrome, but they have different etiologies, different causes, different pathophysiologies. So neuroleptic malignant syndrome, for example, is seen in psychiatry. It's caused by blocking dopamine and giving the medications that do that, the antipsychotic / mood stabilizer, third generation mood stabilizer agents. And so it can happen, and that's not due to an overdose or due to poor prescribing. It's idiopathic when it happens. You can't really predict it. And we do tend to see it in certain demographic types, but it's due to blocking dopamine receptors. But you see many of the same symptoms. The difference is that it takes longer to develop. It usually develops over days or even more than a week, and it takes longer to resolve. The confusion, the mental confusion, tends to be less agitation and aggression and more obtundation. And also you see more of a muscular rigidity and more of a muscle breakdown due to that, as opposed to the twitching and the tremors and the myoclonus. With serotonin syndrome, it can get so bad that the patient can have a seizure. And again, it's potentially deadly, and it is a medical emergency. When it's more mild, the patient will have the sweating and the agitation, and their pupils might be dilated, which is another autonomic sign. So if you catch it early, you can really mitigate a disaster, a medical emergency. But most patients should be admitted to the hospital briefly just to make sure.